has recovered. When the scabs have all fallen off and a fresh layer of skin is forming, then you say that the person is no longer contagious. So it means that from macules all the way to crust time, this person is infectious because they are shedding, the fluids can break, and then they will be staining their beddings and all that. The virus are all over the place. But once the fresh skin is formed, and the scraps are all falling off, the person is no longer contagious. Now, specific antibodies will be present in the blood at the time, and some scars may remain. Now, what are the factors that influence the cause of a monkeypox, M-Pox? Now, the factors that influence the cause, that is how long it lasts, how severe the person has it. So you have asymptomatic infection can occur. Now, protective factors. The person, those of us who are, I'm informed, 40 years and lower probably would never have had any exposure to smallpox vaccinations, whether the person has had any post-exposure prophylaxis with the vaccine, risk factors of severe. So some people, especially amongst children, immunocompromised people, pregnant women and all that, the disease is more severe in people like that. Now, there are danger signs. There are danger signs in M-Pox. What are some of the issues that we should be worried about? What are some of the things that we should be seeing as severely ill and complicated? So people have loss of vision. Once you see that the infection has affected the cornea so much, the eyes are all reddened and all that, and their vision is going down, and people are losing consciousness and convulsing, or they're having respiratory distress. Because of the sores and then the breaking and all that, if the hygiene is not the best, and the person can get superimposed bacterial infection on the skin, and this can lead to generalized sepsis and septicemia, and the person can be very, very ill. Now, you can also, with the danger sign, people can have blood in urine and all that, which can indicate that the kidneys may be getting compromised. Now, so we are talking about some of the complications. As you've seen, look at how the eye of this person has become swollen and all that. This person obviously has it bad. The cornea is infected. The vision is not the best. Secondary bacterial infection could set in, like I said, abscesses. If you have the wounds exposed and there's a superimposed bacterial infection, it could lead to abscesses and things like that. And then encephalitis, viruses, they can go into the brain and cause encephalitis. In pregnant women, it can lead to miscarriages, and then also it can lead to death. Now, what are some of the long-term consequences? So the thing is, you have a long-term sequelae. What can happen? The scarring, we've talked about the scarring of the skin already. So yes, after M-Pox, you can have these things sticking, and then people will be walking about with scarred skin. Their corneas may be or have ulcers, and they may lead to blinding and things like that. We can avert all these things if we optimize the supportive care, and we'll go into that when my colleague takes up the presentation later. And also because of how the skin becomes and all that, because obviously it's out there, the skin is gone bad, things are all over your skin, people are wondering what's it. The stigma can be a problem. It can have a lot of psychological effect on people. So we shouldn't overlook the mental health aspect and the support that these clients with M-Pox would need. Now, considering special populations, I think I've mentioned that, and that the thing is that there's a risk of higher complications in people who are young, people who are pregnant, people who are immunocompromised, and we should know this. It's so important, newborns and all that, and we shouldn't just lump everybody together. Once you have a case of M-Pox, you need to be aware, what are the risks, what is this person a special group, and then we'll go into all that as well, how to manage such people with the prognosis. So what happens when somebody gets M-Pox? At the end of the day, we are saying that M-Pox is self-limiting. It's a viral infection. It's self-limiting. It will carry its own course. And then at the end of the day, everything will be over. But it goes on for as long as 3 to 4 weeks, and having to deal with later on scars and things like that. So usually within 3 to 4 weeks, your symptoms may have subsided and things like that. And the patients are no longer considered to be infectious after all the crusts have fallen off. We are also saying that the West African clade type has a more favorable prognosis with case fatality lower than what we mentioned earlier of the 12s and things like that. And then the Central Basin clade is more lethal, and with the case fatality rate that's hovering somewhere around the 10.6 in unvaccinated children. So differential diagnosis, this is important, especially for our clinicians who are the ones who usually see the cases. So you see a person with a history of fever and then a rash, and it's looking macular and it's vesicular and things like that. Yes, there are other things that could present like that, like chicken pox, measles, scabies. Most children have these, there's a tree name for it. When I remember, I'll mention it, like tomatoes. Yes, the tree people, yeah, we've been saying tomatoes and things like that, hand and foot and mouth, the herpes, syphilis, allergic skin rashes, and drug eruptions and things like that. But when it comes to M-Pox, the commonest distinguishing thing is there's lymphadenopathy, the lymph nodes are there, and then the classic laugh for the face and the palms and things like that can help us distinguish between M-Pox and the other differential diagnosis. So let's quickly jump into investigations, because there are other people on this call who would help us with that. When we want to investigate, somebody comes with these symptoms and signs, what do we do? So I talked about the logistics that we'll need and gave you a tall list of those things that we'll need. We would have to investigate. We'll take a swab of the wound, of the rashes. Okay, usually we want to get some of the fluid in the vesicles and things like that. We want to take a blood sample as well, and we also take samples to check our full blood count and our liver function test and our renal function test, etc. So in a nutshell, these are the things we do when it comes to investigating a case like that. So with the specimen collection, laboratory personnel are here, our disease control officers are here. We want to ensure that the vesicles or the pustules sample is collected onto the tip of the sterile swab. And we want to see, hopefully, that we have an exudate that we can take. So you want to make sure that you have taken the fluid that is in that lesion. And we want to collect 2 specimens, one for separate lesions. So, I mean, if you have face, you can take some on the face, then you take some in the palms and then the soles, that sort of thing. You don't take it from just one side. And then in taking it, you want to vigorously rub the bottom of each lesion so that you get some of the cells and the fluid into the sample. And then you place the swab back into the tube where you could pick it from. And it should not contain, so this is a plain tube, it should not contain any transport media. So if you remember the list, there was also the scalpel and things like the crust. So you carefully and aseptically, that's where you need your gloves and all that, unroot the scab of the crust and place the scab or the crust in the dry, sterile bottle, which should also not contain any viral transference media. Now, you label the tubes. This is so important. I mean, I know that our lab guys are on top of this, but we need to reiterate it. We don't want to get samples into the labs without a name, without an age, without a date. And we must make sure that all these things are also entered into the case-based form. We'll get there, as well as our SORMAs, and because we don't want potholes in the SORMAs when we are extracting our data and things like that. And we want to store these lesions. I mean, we are in a Greater Accra. We are very close to the labs. So yes, you take these things today and you can just walk to the lab the same day and transport it and all that. However, if you're taking a sample elsewhere, you need to preserve it. We need to make sure that they are frozen between -20 and then -70. Now, we transport this lesion specimen to the National Public Health Reference Lab within 6 hours, if you are not going to be putting it into the fridge. And I know that for those of us who are in Accra, it's really, in the metro, it's not that's much of a problem. And it's the National Public Health Reference Lab we're supposed to take these samples. Apart from the lesion samples from the swab and then the scabs from the scalpel and all that, the crust, we also have to take blood samples. And these things are written not because it's important that you know that we want 10 mils of venous blood. We want 10 mils because it matters that it should be 10 mils. 5 mils in the ETA tube, which is the purple covered tube, and then 5 mils in the serum separator, which is the yellow tube. And we want 5 mils. So please, as much as possible, when we are taking these samples, let's try and get the sample, the volumes that are expected, so we don't have to waste resources to go and then we are told, come back because the volume is not enough. And you know, the EDTA we want to swell it a bit so that we don't have an anticoagulant, so that it doesn't clot and things like that. And again, label the tubes. Label both tubes with the person's name and all the details. Now, so case definitions, we need to look at this because right now it is us. As far as I'm concerned, there's no other districts in Greater Accra that has recorded any case of M-Pox. So currently with our case definition, we're going for any person, suspected case, okay, any person who is presenting of any age with an unexplained rash and one and more of the following in the metro. So the person has headache, has an acute onset of fever, has lymphedema, is complaining of muscle pains or body aches, back pain, and profound weakness. And for which, with everything we've talked about, the way the history you take, the lesions and everything, we are thinking that this could be something else. It couldn't be varicella, it couldn't be zoster, it couldn't be measles, and things like that. For now, as much as possible, if we see these lesions, let's suspect M-Pox and take the sample as well. And a probable case is a person that is a case that would meet the case definition for a suspected case and has the following. Maybe the person has a link, an epidemiological link with another case. The person has come to face-to-face exposure, healthcare workers without appropriate PPEs, direct physical contact or skin-to-skin, including sexual contact, or have come into contact with their beddings, the clothing and things like that. We want to identify these people as probable cases as well. And a confirmed case is a case that is meeting the suspected case definition or a probable case definition and has also been laboratory confirmed to have M-Pox virus detected in PCR. And for the 2 cases that we have recorded in the metro, these cases are confirmed cases. Now, the treatments, my colleague would take it up and go through that later. The treatments is largely supportive. I mean, viral conditions, self-limiting. There's no, I mean, the treatment is basically supportive. Now, what we have to do in terms of treatment is to manage the symptoms so well that the person doesn't go into complications like we've talked about. If you don't manage your environment well and the lesions are broken, you can get infected and things like that. Look at the complications, the pneumonias, the corneal scarring, the abscesses. Look out for them. And then also, especially with our special consideration cases in children, in pregnant women, in immunocompromised, we need to look out for some of these complications, be proactive to prevent them, and be proactive enough to identify them when they are there. Now, in terms of surveillance, that is what would solve this challenge for us in a very short time. We need to look out for the condition. That's why we've given out the suspected case definitions, the probable case definitions, and all that, so that we want to be able to what? Identify the cases and what? Report as much as possible. We want to identify and report, and of course, provide the optimal care that these people would need. Now, the indicators for monitoring for quality, if we are saying that we are going to respond, is our response of good quality? What is happening? Are we able to, in terms of the indicators that we use to monitor the quality of this response in the metro, looking at it, what are the proportion of our cases with complete demographic information? And my people, this is so important because, like I said, with the epidemiology, the descriptives, who is this, where did he come from, and all that. And I must use this opportunity to mention this, that the patient's residence, where the patient lives, is a demographic information. And it is so important that, because this is an infectious disease and we have the opportunities from the beginning. The patient comes into the facility, they go to the records collect some demographic data from our clients. What are the demographic data we are collecting? How do we collect them? When we say residential address, what are we writing? Because if you write a residential address like Choco, if the patient becomes positive for M-Pox tomorrow, we are going to be standing in the middle of Choco and be looking into space and not knowing where this person is. That is not a good enough residential address. Be specific, traceable address. These days, people have even digital addresses. People have landmarks that we can collect. And so please, records, let's look at the records and engage people at the records to report these residential addresses very well. Now, even when the patient comes to the consulting room, once the clinicians start thinking that this is an infectious condition, I think the next thing that you should be thinking about is, if truly this is infectious and it becomes identified as positive, we need to do a certain number of things, including going to this person's home. Do we have an address so well enough that we can walk into this person's home, regardless of them helping us and things like that? So please, this one, I'm emphasizing on it, and maybe in the discussions we can discuss it more. Now, what are the proportion of the suspected cases that we are actually testing? So we want to be able to test. If you think it meets the suspected case definition, we need to test. We need to confirm so that we meet our M&E goals. The proportion of cases with complete clinical and risk factor information. We've told you from this presentation what the risk factors are. The people are probably playing with animals, they are cooking animals, they are traveling, they are, all these risk factors. And fortunately, on the case-based form for M-Pox, these risk factors are there. So as much as possible, our clinicians, our disease control officers, health information officers who manage and fill those forms, please fill the forms and ask the questions. Don't leave the forms part and fill. Then when we are looking for risk factors, we can't get it, and then the whole thing is all over the place. So please, this slide is so important to us. Let's look at it and look at it well. Now, the case investigation during the M-Pox outbreak, close physical contact with infected persons is the most significant risk factor. I'll take that again. During the human M-Pox outbreak, close physical contact with infected persons is the most significant risk factor for M-Pox infection. If M-Pox is suspected, the investigation should consist of these. We should take a clinical history and examine the patient with appropriate infection prevention and control measures. Sometimes you are fortunate, so you see the the rashes, because the person comes in later and you're seeing the rashes. So once you see those rashes, yes, consciously as healthcare workers, you just get it. Okay, let me wear my gloves, let me get my face mask and things like that. But we are in outbreak situation. Every healthcare worker should make sure that you are protected, wear your face mask in the facility, because we just told you that droplet infections. Take your clinical history properly, examine these clients properly, questioning the patients about the possible sources of their infection and the presence of similar illness in the patient's community or the patient's household or house, and possible contacts. Please, our clinicians, we need you to help us with this, because usually from records, they go to triage nurses, and yes, can pick up some symptoms and things like that and all that. But the history taking, especially when you think you are dealing with an infectious disease condition, must be taken and taken well. I personally think, and we can discuss this later, that contact tracing and follow-up starts with, of course, contact identification and listing in the consulting room. Because if you're putting down a diagnosis of M-Pox, then it means that you know that this is infectious. And you know that once it's infectious, it means that this person could have infected people along the way. So if you think that, then I think as part of your history, you can and should, as a matter of fact, list the people that you can ask these patients, because the patient is so trusting of you. Patient is in front of you at the time. Ask them, who and who, where have you been, so and so. Take the names down, take the contacts down, take the traceable addresses down and things like that. And as a matter of fact, inform the patient that this is an infectious condition and we are going to test. If we test and it becomes positive, these are the array of things that the system would kick in place. We would come and visit you in your house, and it is for your own good. It's not that we are coming to be nosy and tell community that you have this and that. We are not coming there with a whole big van written M-Pox on it to come and make you get stigmatized and things like that. But this is the system. We have to come into your house. We have to list the people you live in there with. We have to educate people about this, so that when the time comes for public health staff to get into the response, we don't get pushbacks. Because what happens is that, after the diagnosis, my doctor has seen me, then somebody else is calling me. Why is this person calling me? And then we are having a lot of issues. So please take note of this one too. And then safe collection and dispatch of the specimens to the lab for investigation is important. What is the information? I think I've said this so many times. We need the information. The case-based forms have the information that are needed. When is we are seeing the person? Where is the person's reporting location? And I can't belabor this point. Residence of the case, date of their symptoms, date of the onset of the fever and the rash, and whether they've had any travel history and things like that. Recent exposure to a probable or confirmed case, relationship and nature of contact with probable or confirmed case, recent history of multiple or anonymous sexual partners. What work does the person do, including whether they are healthcare workers, smallpox vaccination status, small final case classification that comes a bit later. So let me go with that. Now, with the reporting, the clinicians and other rapid response members should report. And please, another slide that you should take with you is this one, because we've also had challenges with, yes, I saw the case, it met the case definition, but I didn't know who to call. So this slide is for that. When you find a case of public health importance, and in this case, you're talking about M-Pox, meeting all the case definition and all that, you are supposed to report it immediately. Somebody will say immediately at once. So one, when you have it, you're seeing the case, the clinician is seeing the case, you've seen all that, you've taken all your nice history and everything, and you don't report it, it's as good as you didn't see it. So for the clinicians, my colleague clinicians, we want you to know that there's a way we report it, there's who to talk to. So our disease control or surveillance officers are usually the first line group of people that must be contacted. And I've been informed that we are improving that. We are pasting these array of names and telephone numbers in around the case definition, so that you know if you are not able to reach the disease control officer, you have an opportunity to reach somebody else, which is your public health nurse. And then if you don't reach that person as well, you have an opportunity to reach a third person, which is your health information officer. And then if you don't reach any of these three people, you still have the chance to take your phone and reach the head of the facility or head of the sub-district. So that, I mean, you have 4 human beings and 4 different numbers, perhaps even more, to reach. So, I mean, immediately reports, and then these are the people and how you can get the reporting done. Now, let's look at, we talked about contacts because it talks about contact listing and identification. Let's look at who in M-Pox we say is a contact. Now, a contact is defined as a person who in the period beginning with the onset of the case's first symptoms and ending when all the scabs are falling off, has had one or more of the following exposures with the confirmed case or the probable case. So we have told you that there is about 5 to 21 days incubation period. Then you find out that the person is having fever, rash, and all that. So the first symptoms, when the person started having the fever, rash, and all that, and ending when all the scabs are falling off and all that, which we've told you, that's when the person is not contagious anymore. If anybody has had a face-to-face exposure, including healthcare workers without appropriate PPE, direct physical contacts, including sexual contacts, contacts with contaminated materials such as bedding. These are the things that make a person a contact. Face-to-face exposure, healthcare worker attending to the case without PPE, direct physical contact, including sexual contact, contacts with contaminated materials and beddings. Now, the contact identification, the case patients can be prompted, and this was what I was talking about. You have a golden opportunity to take this information from the case that is sitting right in front of you at the time that you have all the opportunity and, for want of a better word, all the power, because you're asking these person questions and they are answering you. This is the time that you have to be able to identify the contacts as part of the history and actually write them down and provide that information to the disease control officer or the laboratory person who is coming to take the samples and is filling the forms and things like that. So we don't have contacts, no. So people in their workplace that they may have had face-to-face contacts with because the symptoms started and he was going to work or she was going to work, in their school, in the nursery, sexual contacts, healthcare workers, including lab exposure, religious, the person went to a church meeting and at that time wasn't feeling well and things like that and was interacting with people in the transport, bars, restaurants, social gatherings, festivals, birthdays, parties, naming ceremonies, funerals, and then the attendance lists. And passenger attendance list, maybe you went to, like I said, a party together or a meeting together, and or you were on the plane together, you were feeling the symptoms, you were having a fever and all that. At that time, the rash wasn't there, but yes, you were having the prodromal symptoms and things like that. So these are the contacts we can identify. How do we monitor the contacts? The contacts should be monitored at least daily for, we've told you that the incubation period 6 to 13, sometimes 5 to 21. So we are looking at 21-day period. You list these contacts. They are followed up from the day they are listed for 21 days, and also asked all the symptoms that can be we've listed: fever, body pain, the rash coming in, the limb swellings and things like that. They are monitored on a day-to-day basis. Either you are going to their homes or you are picking the phone and calling them and they are reporting back on their symptoms. Once the person has any of the symptoms and the signs, then your contact monitoring has picked up a case or a suspected case, you know, and so this is how we do the contact monitoring. Now, the symptomatic contacts, like I said, asymptomatic contacts should not donate blood. Now, asymptomatic contacts can continue their routine daily activity. So you've been exposed to a particular case face to face, that we are monitoring you and all that. That's not the time to be going to blood donation and go and donate. Then you'll be giving somebody blood that is infected with a probable M-Pox and things like that. So this point here, it says that it's, however, prudent to exclude the preschool children. You know, preschool children are a little different. They are very touchy, they are very playful, they can't really wear the face mask. I mean, this issue of IPC and things is difficult to maintain it in preschool children. So as much as possible, if we can, you have prodromal symptoms in preschool children, keep in contact, please keep them away from school and things like that. So the last bit is looking at risk communication. And of course, we cannot manage this outbreak without communicating the risk to the people. This is all about risk. How do I get M-Pox? What can I do to prevent M-Pox? When I have it, what do I do? All this is part of the risk communication, and we cannot respond appropriately enough without looking at this. So we're looking at the preventive measures. What do we do? So if you have someone who has direct contact with an infected person, including sexual contact and all that, you can get M-Pox. So if we've told you this, or you tell your clients this, that direct contact, coming into contact with the skin, face-to-face exposure, sleeping on beddings that the person has been sleeping on before the scabs dry off and things like that, they should be told, this is how you get it. Now, how do you protect yourself? Avoid the skin-to-skin contacts. Avoid face-to-face contact with anyone that has a symptom. Practicing safer sex is important. Keep your hands clean with water, soap, and alcohol-based hand rub, and maintaining respiratory etiquette. This is not strange to us, really, because we've had to fight COVID-19, and these are some of the things we're doing during COVID-19. Like now, I mean, we go to our health facilities and you can't even find one Veronica bucket there, because, I mean, all the things that we have stopped doing, we need to start doing again, and we can't belabor this point. All the IPC measures should be back, and people should be told about them: hand washing, alcohol hand rubbing, and practicing etiquette. Now, when you detect, what do? If people develop the rash and the fever or the feeling of discomfort, they should contact their healthcare provider and get tested. You see, that is what I'm seeing is the missing link here, because I was telling you when I was trying to give you the updates on the cases, I noticed that both of them went to the drugstore, the chemical shop first, and then came to the health facility when indeed they were, like, at the time that they were feeling very down. So the thing had gone on for a while, they were not being, getting the better, and then that's when they come. Why? I mean, my question is, why are people not coming to us first? What is the problem? How can we improve their perceptions? And what is it about resources? And this is us talking about primary health care. Nobody should refuse care if they don't have, even because of cost and things like that. So why are people not coming to us? We should tell them, come to us, you get the care that you need as promptly as possible, and you probably don't have to deal with complications and things like that. If somebody is also suspected or confirmed of having M-Pox, they should isolate until the scabs have fallen off and abstain from sex, including oral sex. We just told you that it's virus, it can get into mucous membranes and things like that. And yes, this line it may sound like, oh, it's easier said than done. Yes, because how do we tell people to isolate? What do they eat? What is the support we are giving for people when we say that you should self-isolate? If somebody is living alone, how do they self-isolate? These issues have come up, and it's something that we need to look at and discuss. During the period, patients can get supportive treatment to ease the symptoms. Anyone caring for a person sick with M-Pox should use the appropriate personal protective equipment and all that. And these points cannot be overemphasized. Now, reporting, we've said that, yes, when you see the symptoms, the rash, the fever and all that, report it. Report it. During travel, upon return, you see symptoms, report it. Is that you see, is as simple as that. You see anything, report what you see, and then let's take it from there. Now, the other thing is, in conclusion, I hope I've been able to update you on our M-Pox situation in the metro and the fact that we have M-Pox cases in the metro. And we all need our hands on deck. Nobody should feel left out. Nobody should feel that this has nothing to do with me, because yes, once it becomes a big deal and it's in our community, then you and I are also at risk. So let's play our roles properly and get the prompt response that we need. So let me just quickly add this so that I don't have to come in again to give the next steps. Our sub-metros and the facilities, we need to update our M-Pox emergency preparedness and response plans. It must be done. I mean, look at what you have already, look at the situation on the ground right now, and then put in the preparedness and response plans. Because if you don't have a plan, you don't go to the chief executive and say, I don't have a plan, but I want money. How do you get money from somebody? You don't have a plan, you don't know what the resources you need, you don't know how you're going to respond, but you want money. That won't work. So let's update our emergency preparedness and response plans, our disease control officers, our rapid response team. Please, let's intensify the surveillance. You know how to do this, and I trust you. Both active and passive surveillance. Passively, we have to look at our triaging. We know that there's an M-Pox. Are the case definitions there? Are our triage nurses updated? Do they know what they are looking for so that they don't miss these cases? Do they know the numbers to call, every point of entry? Do they have the numbers to call and everything? Our public health nurses, community health nurses, those that we have some volunteers who's up. Let's intensify the community engagement. This is not the time to engage the community and not say anything about M-Pox, because we want it drummed in so much that people know what it looks like. People know that when they have it, the facilities are ready to receive them. Let's look for the cases. If we find them in the communities, let's bring them and let's have the samples taken. Let's support our community to get out of this as soon as possible. Our health information officers, you need to, as much as possible, get this done ASAP. Review the records for us for the past 3 weeks. Let's see if probably we started seeing these cases earlier than we started identifying them. Maybe they have come into our facilities, we've missed them, and let's see if we can call them back or identify them so that we can sample. So health information officers, your roles are clear here, and you're also supposed to help us with our data and all that. Our clinicians, our triage staff should have a high index of suspicion, identify these cases and promptly report them. We've told you how and who to report to and all that. If there are any further questions on that, we will take it. Our health promotion officers should develop a communication plan and follow the plan. Because this is not the time to jump at, oh, they say that they are jumping, like you're just jumping around. What is the plan? What do you want to communicate? Where do you want to communicate it? What are the resources you need? And actually just follow the plan. If you don't plan, it means that we are just doing things ad hocly and we will not get because you know the risk communication is so important here. We don't want to be sitting in hospitals and then just collecting cases and naming cases. We want people to be able to stop and reduce their exposure and also report into facility as soon as possible. And so health promotion, let's get this communication plan out and get the work done. For our risk communication and committee members, I thank you if you're on the call. I see about over 100 people on the call or something like that. So I believe that my vets are on here, the environmental team, our NCC, you're here, the information services, you're here, and you know that that's what's happening now. we can, the vets, you can advise us, what do we do, environment, and all that, and then take it from there. As sub-metro heads, you are so critical and important in this, that your leadership in this and the coordinating activities that you let your team do and the provision of the right resources and making them available to them would make a very big difference in this response. Our lab staff, please, you are part of the rapid response team. I'll say it again. Our laboratory staff are part of the rapid response team. We need your expertise in taking the samples and getting it right. We need your expertise in taking the blood samples and all that. So you are part of the team. Don't be left out. Record staff, you are part of the team. I just mentioned that the records we are taking, address, home address, where they are living and all that. We need to improve on that. And you are the best people to advise us on how. Digital addresses, landmarks. Let's take addresses that when we want to go there, we just get up and go there. It's not the situation that the person says choco at Bugulushi and we are standing in the yam market looking everywhere for case A and we can't find. So on that note, these are the references that supported this presentation. And I really want to thank you all for the attention and acknowledge all the senior colleagues that are on here and all of you, and especially my sub-metro heads, for the wonderful work you've started doing so far in this response. Thank you, and over.
Thank you, Metro Director of Health Services. What a powerful presentation. Without wasting much time, we'll call on Dr. Bismarck Opoku Asare. Dr. Bismarck Opoku Asare is the infectious disease specialist, Korle-Bu Teaching Hospital. He is going to give us the next presentation on case management and infection prevention and control. Doctor, welcome. Over.
Well, thank you so much, Michael. Thank you so much, Dr. Louisa and team, for this opportunity. I don't know if I can be permitted to share my slides, please.
Yes, Doc.
Yes. Yes, Doc.
Thank you. Please, can you see my slides?
Yes, Doc, we can see it.
Thank you so much. So Opoku Asare Bismarck. I'm a consultant physician and an infectious disease specialist. And I do some other things. I'm into medical microbiology and all that. Okay, so I'll be briefly sharing with us on how to manage these cases of M-Pox. I work at the Infectious Disease Center at the Korle-Bu Teaching Hospital, and we've seen 2 patients so far that we are managing at our center. Yes, so thankfully, Dr. Louisa has done a great job. She's taking us through a lot of what we have to do under case management. So I'll re-emphasize some of the points so that we can get some more time to discuss. Okay, so usually how will these patients present? Okay, so they usually will present with systemic illness. Usually they'll present with some fever, chills, some myalgia, and usually they'll come in with a characteristic rash. Usually these rash are in the same stage, and they usually follow a pattern. So I'm sure as we go on, I'll show some of these patterns. Dr. Louisa has already mentioned this pattern. I'll just re-emphasize them. And it's important for us to understand that in the past, M-Pox usually has been through contact, been through like airborne transmission, but now it's been clearly shown that it's sexually transmitted, especially since the 2022-2023 outbreaks. So sexual transmission is clearly known, and the 2 patients we actually have at the Korle-Bu Teaching Hospital, they are MSMs, and we suspect they are also retropositive. We suspect that they may have gotten it through sexual transmission. Okay, so usually the clinical progression, the incubation period is between 5 to 21 days, so then after the incubation period, usually they develop the febrile stage. That's between 1 to 4 days. And it's important that the distinguishing feature between M-Pox and the usually measles and chickenpox, they are very close diseases, the very close differentials, is the presence of lymphadenopathy. So for the clinicians here, if you examine the patients and they have this skin rash with lymph node, a differential, you should, as the director has said, you should alert the appropriate person so that samples are taken. Else they use to the rash. Usually the rash becomes mainly the hands, and this rash usually starts. Okay, I'll be grateful. So usually the rash goes through phases. They usually will start as macules, becomes papules, then vesicles, pustules, then it becomes a scab. So usually it follows that sequential stage. Unlike chickenpox, they will not have lymphadenopathy, and they will not. Do you have the rash at different stages? So there are some that are vesicles, there are some that have crusted, there are some that are scabs. That's not like M-Pox. M-Pox, the rash is in a very sequential phase, right? From macules, papules, vesicles, pustules, and then healing and scabbing. Okay, and usually they recover after close to 3 weeks. So, like I said, the initial they come with constitutional symptoms. They can have a fever, headache, myalgia, fatigue, but the most distinguishing feature is that they have lymph nodes. Lymph nodes. So if you examine them, they can have cervical lymphadenopathy, they can have posterior cervical lymphadenopathy, they can have cervical lymphadenopathy, inguinal lymphadenopathy. Classically, M-Pox, they will have lymphadenopathy. So if there's anything you are going to take from this presentation, if you examine patients with skin rash, look for lymphadenopathy. If they have lymphadenopathy, one of your suspicions should include M-Pox. Okay. So usually after the febrile stage, when they begin to have constitutional symptoms, then this progresses to involve lymphadenopathy. They can have some headache, they can have chills, sore throat, malaise, they can have fatigue, they can have respiratory symptoms as well. So it's important that these patients, if you have any suspicion, these patients should be in a respiratory mask. If you can get an N95 for them, that's excellent. But if you can't, at least they should have the basic mask that we use in the hospital on. But if you can get an N95 or N99, that's even better. Okay. And after these respiratory symptoms, they can have some viremia, they can have some lesions in the mouth. Then afterwards, this patient, you begin to have these skin lesions. This skin lesion involving mainly the face and the extremities. Okay, and like I said, usually the lesions progress through sequential stages, usually as from macules to papules, vesicles to pustules and to scabs. And usually the greater the number of skin lesions, it's actually been shown to have a prognostic value. If you have more than 200 lesions on the skin, these patients are at risk of severe illness and could even die as a result of M-Pox. So I think I've mentioned this already. Dr. Louisa has mentioned this in her slides, the various parts of the body that's involved. But currently, in any patient with M-Pox, because now there's clearly sexual transmission has been shown to be a clear risk factor, you need to make sure you examine their genitals. Okay, I have some pictures, so maybe at a point I'll show some of the pictures. Okay, so because of MSMs, so these patients can present with a prostatitis. They can present with ulcerative pharyngitis or tonsillitis. They can have ocular involvement, and that is a danger sign if they are beginning to have conjunctivitis, blepharitis. They could have periocular orbital cellulitis and all that. That's quite concerning. And they can also have an encephalitis as a result of M-Pox. Okay, so these are various skin lesions. These skin lesions look like I don't know whether I can. Is there any way of enabling? Oh, let me see if I can have a pointer. Pointer. Okay. Oops. Okay. So forgive me. So here you have pustules. These are mainly pustules. Okay, mainly pustules or pustules, some papules on the patients. These are patients we saw in the Kolibu Teaching Hospital. Okay, these are so the male patient had retroviral infection, and he had these pustules on the face and in the upper limbs. This middle-aged woman also had a lot of genital papules and vesicles, okay, in the genitals and in the extremities as well. Okay, so the danger signs, as has already been mentioned, you talk about if it involves the cornea, the eyes, you have risk of loss of vision. If it involves the CNS, you can have delirium, loss of consciousness, you can have convulsion. If it involves the respiratory system, you can have some respiratory impairment, including respiratory distress. You can have superimposed bacterial infections, okay, and that can lead to sepsis. And you can have it because there's a viremia, you can have it involving the kidneys, and you can have blood in urine and or inability to produce urine as the disease progresses. Okay, so if all these, like I said, have been mentioned by Dr. Louisa, so she's made my work easy. But if you've ever had any smallpox vaccination, but for a lot of us, we are probably not have smallpox vaccine, except those who are working in very special labs who have had vaccinations. Okay, so we may not have this. There's a principle of ring vaccination where those who are very close contact are actually vaccinated. They have vaccines, especially in DR Congo and some of these countries where they've had very large outbreaks. They are doing what we call ring vaccination. So you vaccinate the very close contacts of the patient. So that's why doing a line listing, getting the contact who is being in contact with, assessing the degree of the contact is important, because you may need to vaccinate these contacts. And if you vaccinate them within 4 days before, 4 days, within 4 days after they have had the exposure, it's been shown to reduce the risk of developing M-Pox. And even if you vaccinate them between 4 to 14 days, even if they are going to get the M-Pox, the severity is less. So it's important if you have some vaccines. Then there are some high risk patients, like children, patients with immunodeficiency, retroviral disease patients, patients who have invasive route of infection. Patient with the clade type is important. The clade 1 has more severe, it's more severe, and you could have more case fatality of up to 10.6%. But if it's clade 2, that's what's in the West African region, it has less severity, and case fatality is about 3.6%. So if you have a research lab that can tell you the clade, it can give you an idea of the severity of disease. And when they begin to form scab, like Dr. Louisa said, usually within 21 days after the disease has started, usually means that if the scab and their skin has healed nicely, then they are non-infectious. So in patients, thankfully we are having few numbers, but God forbid, if you have more patients, then there's a possibility that you can let some patients self-isolate at home. And in these patients, they have to self-isolate till their skin has completely healed. There's new skin over these lesions. Then they are non-contagious. If not, they have to remain at home till this happens, till their skin completely heals. Okay, some complications, you can have corneal infection, you can have secondary bacterial infection, you can have abscess, airway obstruction, you can have sepsis, you can have encephalitis. In pregnant women, they can miscarry, and the patients can die as a result of these complications. So in management, for now, because we don't have too many patients, we are advocating that as much as possible, we manage these patients in hospital. So far, all the 2 patients we've had, we are managing them in hospital. But if the patient is very stable, maybe has a few skin lesions, has no respiratory involvement, is very well, and patient can isolate, and this can be, you can guarantee that this patient can isolate. You can actually keep these patients at home for the period of 21 days till all their skin lesions have healed. Okay, but if for most of our patients, and for the patients we have now, we are keeping them in hospital. And it's important to know that M-Pox is transmitted by contact, whether direct or indirect. You can have airborne or transmission, but the most effective way it spreads is through contact. And there's a need to isolate these patients and manage them to prevent further people from getting the M-Pox. So the patients we've listed, the patients who are, for young children, patients who are pregnant, patients who are immunocompromised, both patients have retroviral infection. So there's a need to keep these patients in hospital. Then if for our patients, all those we had, we quickly do a retroviral screen for them. And if their CD4 count is less than 200, we quickly start them on antiretrovirals. I mean, if the CD4 count is less than 400, the risk of getting severe disease is higher. But whether their CD4 count is less than 200 or greater than 200, we test and treat everybody. But just in case the resources are challenged, those who have CD4 less than 200 should immediately be started. But as much as possible, all the patients we have who also have retroviral infection are initiated on antiretroviral therapy immediately, and if they have some other opportunistic infections apart from M-Pox, you go ahead and treat them. Okay, and you want to start them on ARTs as soon as possible. Okay, so pregnant women, it's unknown if these pregnant women are more susceptible to M-Pox or if infection is more severe. Okay, but we are concerned that because they could possibly spread it to their babies and all that, there's a need to keep these patients in hospital. And you want to also rule out some other infections that you could have in pregnancy. Okay, but like I said, if it is M-Pox, usually classically they have generalized lymph nodes. So if it's M-Pox, with all these skin lesions, mainly in the face, the hands, that is progressing sequentially from macules to papules to pustules to before it's scabbing, then you certainly need to rule out M-Pox. Okay, so it can be transmitted to the fetus. So you need to make sure we are keeping them in hospital. We are observing them closely. Okay, and after we'll talk about whether they can breastfeed and all that a little later. But because they are higher risk of developing adverse deliveries, like having pregnancy loss, stillbirth, preterm, and these patients must certainly be kept in hospital. So you don't see a pregnant one who has M-Pox and say, okay, you are looking very well, go home. You have to keep these patients. If you have an isolation in the hospital, quickly send her to the isolation. But if not, I'm sure you can contact my boss, Dr. Oliver Komi, at the Ghana Infectious Disease Center, and you should get some help. If not, I'm sure you can contact Dr. Louisa. She'll reach out to me and we can possibly help you as well. Okay, so after delivery, you need to isolate the mother, and and you want to avoid direct contact with the newborn as much as possible. But if the mother agrees to breastfeed this child, then you need to put in some precautions. You want to avoid direct skin-to-skin contact with the mother. So the mother has to have a face mask. It has to be if you can have a gown, you should have a gown that covers all the skin. Have a face mask, and hopefully we shouldn't have too many lesions on the breast. Then you make sure that then the baby can breastfeed, but the baby should be fully clothed or swaddled so that there's very little contact between the mother and the neonate. Okay, I've seen Dr. Nyako on, so I'm sure she's concerned about these babies. Okay, so so it says if the patient chooses to have contact, then you have to do strict precautions should be taken. After contact occurs, clothing or blanket should be removed and replaced. The gloves and a fresh gown should be worn with all visible skin below the neck covered. Soiled linen should be removed, and parents should wear a well-fitting medical mask. Okay, this precaution should be continued until all the lesions have resolved. Like usually, it can take up to 21 days. Okay, and the newborn that is born to people with M-Pox should be placed in isolation, and you should make sure you are supporting the mother, getting psychological support for the patient. Like Dr. Louisa said, a lot of what we're doing during the COVID period also applies here. A lot of people are quite traumatized by M-Pox, and you need to make sure they have some psychological support. Okay, so if they are going to breastfeed, and I'm sure our pediatricians would agree, the breast milk is the best source of nutrition for these neonates. Okay, and it's unknown if monkeypox is present in the breast milk. But breastfeeding should be delayed as much as possible, if it's possible, until all the skin lesions have healed. But if the mother needs to breastfeed the child, they can express. Okay, you can have a caregiver to also feed the child with infant formula. But if it's absolute necessity, you want to make sure that, the mom wears gloves, she has a surgical medical mask on, she's well clothed, and there are no open skin lesions. Then, then if that's the only resort, then you can let the baby breastfeed, but the baby should be well covered so that there's very minimal contact between the mother and the baby. But as much as possible, if breastfeeding can delay for up to 3 weeks and other infant formula use, that's preferable, because skin to skin contact really increase the risk of the neonates getting M-Pox. Okay. So for children are also one of these high risk group, and they have very similar signs and symptoms to adults. Okay, and usually for the clade 1 in the past, it was called the Eastern African clade, or the Congo Basin clade. It's likely to be more severe in children. Okay, so if they have clade 1, then you should give some particular attention to these children. You must monitor these children closely. You must keep their skin lesions covered. Okay, and as much as possible, you want to prevent these patients from scratching the lesions or touching their eyes. So you need to give them some antihistamine so that they reduce itching. And you want to ensure that they are taking adequate fluid so that they don't develop dehydration, acute kidney injury, and all that. So prognosis-wise, M-Pox is usually self-limiting, and it usually resolves between 3 to 4 weeks. And usually, as long as the patient, their skin heals completely, their crusts are falling off, they are non-infectious. The clade 2, like I said, has more. The West African clade has more favorable prognosis, with a case fatality of about 3.6. Clade 1 is more lethal, with a case fatality of up to 10.6%. Okay, so these are important differential diagnoses. Okay, but chickenpox especially, you have it involving the face, the other parts of the body, but thankfully the skin lesions are in different stages. You can have some as vesicles, you can have some having healed, you can have some as pustules or papules, but that is not like M-Pox. M-Pox, you have the lesions going sequentially. So you have first macules, you go to papules, you can have vesicles, then have pustules, and then the lesions scalp. Okay, but chickenpox, you have at different stages. okay? And usually they don't have a lymphadenopathy. But if it's M-Pox, classically, they have a lymphadenopathy. Measles, measles, you have these classic Copley spots, and they don't also have lymphadenopathy. So usually the greatest distincting feature is the lymphadenopathy that these patients have, okay? But you must also know that you can have co-infections with M-Pox. You can have varicella with M-Pox. You can have measles with M-Pox. You can have scabies and all that with M-Pox. Okay, so this is a picture to show M-Pox. You know, you have the same stage. You have the same stage of the rash all over the skin. Okay, but if you look at chickenpox, some have healed. Some there are macules. There are some papules. There are even a few vesicles, mainly on the back. If you have the measles patients, they have all these some also different stages of the rash. If you check their mouth, they have complex spots. They don't have lymph nodes. Okay, so I've already spoken about this. Okay, so this a patient with varicella, a patient with molluscum contagiosum, a patient with varicella zoster, a patient with disseminated cryptococcal infection. That's also it's also common in our HIV patients. We've actually done some studies at Kolebu. Patients with advanced HIV, we have about 4% of them coming with cryptococcal, either meningitis or cryptococcal skin diseases. So it's not that rare. Okay, and you can have disseminated gonococcal infection. Yeah. So the treatment is mainly supportive. You know, the treatment is mainly supportive. You can give your antipyretics if their temperature is high. If they are not able to take in a lot of fluid, you need to give IV fluids. Okay. And if they are having some challenges with oxygenation, you need to give them supplemental oxygen. If you think they have a superimposed bacterial skin infection, you need to give them antibiotics. And if you have a co-infection with varicella and all that, then you need to give them acyclovir. Okay. Just to re-emphasize some of the things Dr. Marty said, you know, for prevention, you must avoid contact with animals that could harbor the virus. You must isolate infected patients from others who could be at risk or infect. So even if you don't have an isolation, you need to keep these patients in a single room where they are the only people in that room. Okay, you must practice good hand hygiene. Okay, you must wear personal protective equipment. You must make sure if you are going to see these patients, you have a gown on over whether your scrubs, whether your clothing, you have a gown on. You must make sure you have a medical mask on. You get goggles to cover your eyes. You double glove. Okay. You make sure if you don't have Wellington boots or Wellington boots is preferred rather than getting maybe shoe covers and all that. If you have Wellington boots, that's better, so that after you are done seeing the patient, this can be taken off. Okay. And anyone going to enter the patient's room should have these personal protective equipment, because if you don't, then you become a contact. And as much as possible, we don't want our healthcare workers becoming contacts and having to stay off work and all that and exposing them unnecessarily. Okay. So during so basically you must make sure you admit the patient. If you have a negative pressure room, that is most ideal, but a lot of our places we may not have that. But I'm sure if they are sent to the Ghana Infectious Disease Center or they are sent to our center, we have a negative pressure room. Okay. And if possible, you place this patient in a private examination room and make sure the patients themselves wear a mask that covers their mouth and nose. Okay. You should get them to wear a gown or a clothing that covers all these skin lesions. And you must make sure there's a confirmation of the diagnosis. And I'm sure if you contact, like all the contacts Dr. Marty listed at your center, you should be able to do that easily. Okay. So yeah, so measures during home isolation. They should be able to have a place they can stay alone, and have washroom, and not mingle with the family till their skin lesions have completely healed. Usually that takes up to 21 days. Okay. If they can't do that, you probably would want to keep them in hospital. But for now, since we don't have too many patients, we can possibly admit all these patients. Okay. Yeah. So, like I said earlier, the smallpox vaccination gives 85% protection. There are there are newer vaccines, but in country, as much as I know, there are none of these vaccines that are available. Okay, so there's ICAM 2000. I mean, that's being used in other centers, in Vanex and all that are available, that have been used in DR Congo. I'm sure if there's a real need, I'm sure the government should be able to help with that. Okay. Then there are some, just for those who are, just want to know more, there are some antivirals that have been shown to be effective. It's currently not in country. There's tecovirimat, there's cidofovir, there's brincidofovir, there's Nioch. All these antivirals are available in other places. But thankfully, if you do your good supportive care for these patients, invariably, all of them will recover well and will not need any of these antivirals. But if you have them, or you have some means of acquiring them, then it's available in other places in the world, or in other places in the world, and you can possibly use that. So in summary, like Dr. Mate said, it's a zoonotic disease. It's usually presents with systemic illness with a characteristic rash. So the rash are usually mainly in the face and the extremities. They occur over in a sequential manner. So they start as macules, they progress to papules, they become vesicles, they develop, become into pustules, and then they crust, or they have scalp formation. And usually, virtually all our patients we've seen, they have lymphadenopathy. So okay. So it's important to distinguish from other rashes, especially chickenpox, measles, and all that. But you should make sure, as a healthcare professional, you wear the appropriate PPEs when you're managing these patients. Okay. So I'll pause here. These are my references. If you have any questions, I'll be here to answer them. Thank you so much.
Thank you, Dr. Bismarck Opoku Asare. At this time, if you have any questions, contributions, show by hand, or you let us know, and then you go ahead. Someone on the line?
Hello.
Hello.
Good evening.
Good evening.
Okay, so my name is Rabiu Babatunde Mohammed, a social mobilizer in the community volunteer from Okakisa subnetwork, Mukuse Chiefs compound to be precise.
Okay, please go ahead.
My question is to Dr. Adamki concerning these cases we are talking about. For those of us with the kind of portfolio I have, meaning we are to educate the people and create the awareness of the presence of this outbreak for mothers and caregivers to be aware of this condition and what to do when they detect such cases. My question is, service provision in terms of vaccination and treatment of this cases, are they free or do they come with a cost? So that when we are educating them, we will know how to give them the right information in order for them not to also fear reporting the case and bringing it to our notice. Thank you.
Thank you. Over, Director.
All right. Thank you. I mean, it's a very good question. As a matter of fact, you have brought up something very important, which in the response of disease of public health importance, especially when we are dealing with outbreak situations, we always want you to remember that the government of Ghana, the Ghana Health Service, does not charge anyone a dime to manage an infectious disease. So when we're dealing with cholera, we were saying that the management, the treatment in hospital is absolutely free. And it's the same thing we are saying in this outbreak. Management of M-Pox is free. So once you get into hospital and it is that you have a fever, you have a rash, and so on and so forth, nothing whatsoever will be taken from you once that diagnosis of M-Pox is made. So that is what it is. As much as possible, please don't let cost and fear of charges and those things be the reasons why people will not come. Just tell the community members that when they have these symptoms, they should come into hospital. And once we make that diagnosis that this is what we think it is, the testing and the sampling and everything is free. And if we have to isolate in hospital, like doctor said, take to Korle Bu or even the KID, the Infectious Disease Center, the care there is also free. Thank you, and over.
Thank you. Are there more questions?
Yes, please. I have a question for Dr. Asare. I joined a bit late. I had challenges joining, but I wanted to find out. So if a patient walks into the hospital, like I work at a polyclinic, the patient walks into the hospital and you can obviously see the pustules and the vesicles and things at the same stage, and you suspect it's M-Pox. What is the drill like? Because usually the patient goes to records, and then patient joins the queue at the OPD and then gets the vitals checked before they come to the consultation room for. So at the point of the patient entering the hospital, where do you get the PPE for the records person? How should the drill be like? Should you immediately get PPE and isolate the patient on suspicion? I just wanted a practical view on it.
Thank you so much, Dr. Dufo. I'm not surprised they're asking this question because actually the two patients we picked up so far came from the polyclinic at Korle Bu. So the aim for sessions like this is to increase awareness. If let's say our triage nurses or if let's say even our records people are well enlightened about this infection and they see any patient like this, they should quickly inform maybe the triage nurse or whichever doctor is on duty so that this patient is quickly isolated. If you don't have an isolation room or something, the patient should be able to, just a screen and kept from all the other patients, put on a mask so that all the other healthcare workers are alerted. Then, whichever doctor is on duty can wear the appropriate PPEs, see the patient, and subsequently inform public health. When they inform public health, okay, so those who are in Ghana Health Service, Korle Bu is a little different. So what I'm talking about is mainly for Korle Bu. I don't exactly know what happens in Ghana Health Service because I don't work in any other facility. So I'm sure Dr. Louisa will fill that in. So usually you inform public health And as soon as public health is informed, they will usually inform us as well. And for now, we have a clear agreement. Even if the person is suspected, we admit the patient. So all those two patients, we actually had admitted them for about 2 to 3 days before the results came, and it came positive. So if there's any suspicion at all, the patient should be isolated. If there's no isolation room, get a comfortable chair for the patient to sit on. Get a mask for the patient. Then whichever healthcare workers are going to see where the appropriate PPEs and inform public health, they'll come over, take a sample, and inform us. When they inform us, we'll admit the patient. Okay. Abna, you okay?
Yes, please. Thank you so much.
Just to add to that.
Okay. So okay. So I'll leave it there if there are any further questions. Thank you.
All right. Just to can you hear me?
Yes, we can hear you.
Just to add to that, it's very similar in the Ghana Health Service scheme of things as Doctor has described. The thing is that now that it's come to our attention that we have this in the metro, all of us in the metro, be it whatever level of facility, small private facility, big one, whatever, we should sensitize our staff. And by sensitizing our staff, we are talking about right from the entrance, the security post, all the way to the last point. You know, because like you just described, Dr. Abna just described, the patients could come into contact with the security, who will probably be directing him or her, stand so close, and sometimes even maybe they're even wielding and things like that. So the thing is that everybody must be aware that we're having this. And the records point, I would advise that at records, if you're at work, please wear a face mask going forward, because you interact and speak with so many clients that you don't know what any of them is carrying. So even sitting there the whole day without a face mask is in itself a challenge. So I would advise that all people at records, everyone at the triage should also be in mask. And yes, we've told you the classic presentations and all that. So if you see that, yes, it should ring a bell. Once you see this classic rash, we are even fortunate the person is not in the stage 1, so you are not seeing anything, but you are seeing this classic rash and all that. It should ring a bell that these patients may be infectious and things like that. And at this point, remembering lessons we learned from COVID, I would humbly suggest that every facility, be it private or public, every kind of facility should at least have a place that they can call a detention corner or a holding area, because even if we call infectious disease center or Kolebu that you are bringing in the case, you would have to hold that case at least for some time. So you need at least a holding area, if nothing at all, where you can keep a patient for some time before we figure out how you're going to move. And yes, the movement too is a thing. If the patient came in a taxi and all that, and the taxi is gone, you know that, oh, then this person may have come into contact with this taxi driver who is gone. But the taxi driver is around and the person came with that person, Uber and all that, and they are not masked, you know that this is close enough for contacts for us to say that this taxi driver is a contact and let's list it and things like that. So it's just a picture of us looking at this as an infectious disease and asking ourselves in every step of the way, which infection prevention protocol has been breached and who is a contact and all that. For as much as possible, let's try so that we as a healthcare workers do not unnecessarily become contacts to these clients when they come into the hospital. And then last thing, I would also say that our heads of facility, now that we know that this is around, let's try and provide the resources, the face masks, the gloves, and sensitize our staff to be able to wear them and use them appropriately and dispose them of appropriately so that they don't get unnecessarily exposed. Thank you.
Thank you, Director. Any more questions?
Okay. Rabiu again on the line. I want to know what measures or are there measures being put in place to engage the various over-the-counter medical sellers within the Accra Metro? Because as we know, some of our people within the communities will choose to just walk into a certain pharmacy and then give a brief complaint that Papa Doctor, that is what they used to call the pharmacist most of the time. Papa Doctor, Papa me buy you home. You do now which media man. In a case like that, what has been put in place for them to also be aware of this so that they don't also go ahead and just administer a random skincare product but rather also assisting in educating and making sure that people visit the appropriate facility for a proper check and diagnosis for this symptoms we are talking about. Thank you.
Thank you again. You make very interesting points, and I'm happy that you joined this training. As a matter of fact, the point you just made is so important because in my summary, I mentioned that two of the two all visited chemical shops and all that before coming to us. So you are very right that quite a number of our clients may be visiting these chemical shops before they come to us. And that is where our community health nurses, our public health nurses, and you, our community-based surveillance volunteers come in. And of course, our health promotion officers also come in. So this is where I would say that our community health nurses, the public health nurses on the call, and of course, some of the community health nurses on the call, we need to scale up this information to them. This is what is happening. If you're a community health nurse and you're working in a certain chip zone, technically all the chemical sellers and all that are part of your health system that you should know about. And I know that some of our community health workers already engage these chemical shops already in terms of collecting data for our family planning information and all that. So engaging the chemical shops shouldn't be a challenge for our community health nurses. So in short, what I'm saying is that we would expect and encourage our community health nurses to list and engage these chemical sellers. And also, you see, you engage, you leave your number there, you tell them that, okay, this is what it is, show them pictures. And then when they have such cases, they can call you and say that, oh, we have this case, blah, blah, blah. Probably even leave them an exercise book to register these cases, leave their numbers, and then contact you. That is one of the things, because we know that the community member going into the chemical shop, they probably didn't want to come into the facility anyway, and now you are giving their number to. We have to be tactful about it, see how the chemical seller can engage us when they see these things with the consent of the community member, share the numbers, and then we can follow up and see whether indeed how the thing is looking, and then pick the samples as and when. So what you said is fantastic. We need to be collaborative and partner with the community, the chemical sellers. And I'm saying that our community health nurses and public health nurses should take up this and do it. My other colleagues are on the call, and I don't know if anybody has anything else to add. Thank you.
Thank you, Director. Are there more questions, contributions? There are no more questions and contributions. Then I'll call on the Metro Director again to give us the closing remarks. Director, over.
Thank you so much. I think my senior colleague is on the call, Dr. Farida Abdullahi. Yes, I see you on the call. If you could say a word, that's our Deputy Director of Public Health for Greater Accra. If you could say a word or two before we close. Oh, okay. I don't see her anymore. All right. So,
Hello.
okay. Thank you, Director.
Thank you,
Thank
Director.
you very much. Good evening, everyone.
Good
And
evening.
thanks for this opportunity. So I've been listening to the presentations and I've learned a lot. I hope we all have too. Greater Accra, as we all know, any outbreak that hits the country, unfortunately, we get more than our fair share of it. And this time around is M-Pox. I'd like to just entreat all of us to do the best as we can to ensure that it ends with these two cases and then we don't get more people being infected. It's very important for us to take the risk communication very seriously and ensure that we spread the word to the community members so that they can protect themselves. And when they do reports to our facilities, IPC, very, very critical. I remember the last time we had the Lassa fever outbreak. Unfortunately, we ended up having more healthcare workers getting infected than even community members. So, but fortunately enough for cholera, we didn't see that, and we are hoping that for this outbreak too, that wouldn't be the picture. So I'd like to thank you all for your efforts. I hope that together we can end this, nip it in the bud, as it is said. Thank you very much, Metro Director and team, for all the hard work you continue to do. Thank you. Good night.
Yeah, thank you, Director. Thank you, Director. So on this note, I'd like to say a very big thank you once again for making the time to join. I'm so glad about the numbers. I'm hoping that, I don't know, I think maybe the limit was 100, so we couldn't accommodate more of you, but we appreciate your coming. We appreciate your staying to the end, and we hope that this will make a difference. Please, we are just a call away. We are just a text away. We are just an office away. Please don't hesitate. In your sub-districts, you have your sub-district heads and the teams at the district level. You have us at the metro level and all that. Please engage us, talk to us, give us all the suggestions that you have, and also give off your best in the facilities to get this nipped in the bud, borrowing Dr. Farida's phrase. So once again, I say a very big thank you, and I thank you, especially the private facilities for coming into this, making the time to join this call. And I hope that we'll be able to address this as quickly as possible and get it over and done with. On that note, thank you. One more thank you to Kolebu. I must say this, Kolebu, you've been fantastic. You've been swift. You've been supportive, and I thank you for holding us on the fort on this for us. And Dr. Asare, special thanks to you for agreeing to support us in this training. On that note, I wish you all a very good night, and I'm sure we'll meet again in other quarters. Thank you, and over.
Thank you, Director. Thank you. Or shall we call on Rabiu Mohammed to give us the closing prayer? Rabiu.
Yes, sir.
Yeah.
Okay, so Muslim prayers, please. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين.
Amen. Thank you very much. Thank you all for joining. Thank you.
Bye-bye.
Bye.
Bye.
Bye-bye.
Bye.
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 And please,
Hey. Oh, nice.
Driving for my work.
Hmm.
Take me out.